So we talked at the beginning that a large part of our discussion today is about thrivership and how to live well with neuroendocrine cancer. And a big part of that is managing symptoms. And I'm sure that's a lot of your discussion with your care team. And now we're going to have a great presentation on that from Dr. Kim Perez. She's a senior physician at Dana-Farber Cancer Institute and an assistant professor at Harvard Medical School with a focus on NETs and GI cancers. Dr. Perez?
Thank you to all of you for coming out. This is really great, and thank you so much, Elise and NETRF, for having me this evening. It's fun to see everybody not in the clinic. So I'm going to go through this, and it's sometimes a little bit tricky when we talk about symptom management, because I think the one thing that many patients share with me is that when they start talking to other patients with symptoms, no one seems to have exactly the same symptoms, or they have the same symptoms, but it seems to happen to one person one way and another person another way. So I'm just going to do a bit of an overview here on what's available and how we can approach it. But you may walk out of it or think, I don't know if that applies to me, or hey, I think that applies to me. So it's just meant to be somewhat just thought-provoking and just obviously just a way to allow you to advocate for yourself with your clinical team. So I'm going to start with just discussing what carcinoid syndrome is and why does it happen and what are the treatment options that we have. So carcinoid syndrome, the term itself confuses many patients. So whenever I meet a new patient, they say, I've looked in the internet and I think I have carcinoid syndrome. And we have to kind of tease out, just as Dr. Halfdannerson worked with you all today, was just kind of working through what are all these terms, and I'm going into the internet and I have carcinoid, but I think I have neuroendocrine, and I have a syndrome, but I don't have any symptoms, and I think I had diarrhea yesterday, but is that the carcinoid? I'm not really sure. And so that's where I try to talk through with new patients that, and with ongoing patients, carcinoid syndrome is a response to hormones or signals that are coming from the tumor cells. And the normal neuroendocrine cells, that's what they do. They are sending signals to tell different parts of your body to react to the environment, to some kind of stimuli. The problem is when the neuroendocrine cell transforms to a cancer cell, all of a sudden that signal potentially is just happening without good cause or without the right triggers. And so things like skin flushing, diarrhea, shortness of breath, belly cramping can all happen because the neuroendocrine system helps coordinate those normal functions. So it helps you when you eat something, the only thing you have to think about is chewing it and swallowing it. And then the rest of it just kind of happens. You've never had to think about it. But that is part of what the neuroendocrine system is doing. It's coordinating, telling your esophagus to push the food down, it's telling your stomach to make some acid to help break down the food, telling the intestine and the colon to move things through. And then some people will say then sometimes within an hour, a couple hours of eating, I feel like I have to go to the bathroom. That's all that coordinated function. It's kind of a simple plumbing system. And so that's, the carcinoid syndrome is really just that trigger of all these symptoms, or kind of a trigger to the normal unaffected system that doesn't know that the signal is an inaccurate or a false signal. Sometimes, in carcinoid specifically, it's because of an elevation of serotonin. And so there is, and many of you may have collected your urine for 24 hours to assess this level, but it's one of the few labs that we're able to do to just determine what the level of the serotonin is in the system. And there's different, as you all have probably come to know, there's different, the neuroendocrine system can be present in many different organs, and so your primary tumor may be in the pancreas, it may be in the small bowel, maybe in the lung, and all of these sites can have the potential to release the serotonin, but they also have the potential to release other neurohormones that are normally produced by the neuroendocrine cell in that organ. And so this is why it happens. So the why is that the neuroendocrine tumor cell makes the serotonin, it gets broken down in the body, and then it goes through the system and it goes to these different organs like the liver and the heart and the skin and the lungs and the GI system, and it overstimulates it. So all of a sudden, you're having diarrhea that you'll say, I didn't eat anything all day, and I'm still having diarrhea. Or someone will say, I was sitting calmly, not doing anything, and my heart feels like it's just pounding out of my chest. Or sometimes when I eat chocolate or have caffeine, my face gets really red, or my partner looks at me and says, are you okay? You look really, flushed or warm. So different symptoms that can come of it. So I mentioned the 24-hour urine. I saw a couple of people's heads nod, because I don't know if there's anyone in the room who's ever collected 24 hours of urine and said, yes, that was really fun. I can't wait for her to ask me to do it again. So the one thing I want to make sure of, and it's always hard, because when I suggest to a patient they collect their urine, there's so much going in the visit, right? And so there are things that could influence what your levels are going to be, because these hormones are supposed to be in your body. The problem is that the neuroendocrine tumor cell is making the level at an excess that your body doesn't need. But since it's supposed to be in your body, it can result, when you eat certain things or do certain things, that level can go up, and it's not an indication of disease activity or excess hormone. It's just your body's doing what it was supposed to do, right? And that can be very confusing. And so we do suggest that you limit your tryptophan-rich foods when you're going to collect it, because it's a big task. So let's get as much out of it as we can. We don't want to have to try to do it again, where the number is supposed to be under 8 and yours is 9, and you look at me and you say, 9, and I say, don't worry about it. And you're like, really? Why did I just do that if it's positive and you're telling me not to worry about it? So that's some things that you can consider. So I'm going to go more specifically into some of the symptoms. So we've talked about the diarrhea, and I think this is probably one of the more common symptoms that patients experience or can describe when they have carcinoid syndrome. So again, not everyone's going to have diarrhea. Not everyone with neuroendocrine tumors have carcinoid. But if they do, they can have this type of diarrhea where it doesn't matter what you do with what you're eating. It can happen any time of the day or at night. It can sometimes feel like there's some urgency to it, some abdominal cramping with it. And it's all of those things that result in seeking medical attention, trying to figure out what's going on. The transit time when you have somebody who has carcinoid compared to someone who doesn't. So that's the little table I've included. So overall, it typically takes 25 hours for a person who doesn't have carcinoid to eat something, and that's what is expelled. With someone with carcinoid, it can be as quick as 12 hours. So it's just a shorter period of time. What's tricky with neuroendocrine is that many patients I meet have already had a surgery to remove their neuroendocrine tumor. And they'll say, well, I'm having diarrhea. Does that mean the tumor is still in my body, and that's what's making me have diarrhea? Fortunately or unfortunately, there are a lot of other things that cause diarrhea and can appear or affect individuals in a very similar way. So after surgeries, especially bowel surgeries, people can experience diarrhea. Some people can develop what's called pancreatic insufficiency, which means their pancreas, just like any other organ, ages and it's not making the proteins that you need to help break down your food. And so then you have the floating stool. It's a question that I ask many people, and they look at me like I'm not staring in the toilet, but I think I can answer the question. And then there's something called bile acid diarrhea, which is just when you're, and this can also happen with time, it's just you're not, the gallbladder that holds on to your bile that helps you digest your food is just not being produced in a way that allows you to effectively digest your food. So then you're having the sense of, you just all of a sudden have to go, okay? So that's where all of these are a little bit different. And then this very busy slide is not anything that you should try to memorize or take a picture of. It's just to reassure you that we have lots of options, right? And we are trying to be very thoughtful in when we're sitting with you as your care team and saying, okay, when do you have it? How bad is it? And what are you taking? And what can we add to what you're doing to make it better? And it's not going to be a one-trick pony for every single patient. And that's why I include this very colorful slide with lots of arrows on it, is just to reassure all of you that communication is key. Tell your provider what's going on, what you're taking, how you're taking it, and that's what's going to help you manage your symptoms. And then the antidiarrheal medications, so there's a few. The one that we commonly use when someone has carcinoid syndrome is somatostatin analogs. It initially was offered in a short-acting form, so we will offer patients that if they are finding that their diarrhea is still occurring despite being on a long-acting somatostatin analog. And then there's the antidiarrheal loperamide. You may know it as Imodium. That is over the counter. There's atropine, that is Lamodal, and that is something that some providers will prescribe when the Imodium just doesn't seem to be enough. And then there's some opiates, and one is tincture of opium, which is a liquid form that's sometimes prescribed when all of these things are not working. Let's see. And I didn't include, and I apologize, there's maybe I have a slide on it. If I don't, I'll come back to it. And then there's the dietary modifications. Again, this seems counter to what I said at the beginning, that there's no correlation with what you eat and what you don't eat, and you still have it. But there is some benefit of trying to narrow the diet when it really is at kind of its peak. And it's just to simplify things, eat frequent small meals, take in things like Gatorade and Pedialyte just so you don't become dehydrated or low on minerals that are important. Avoid things like dairy, cheeses, sausages, wine. I always find it funny or fun when someone's calling me and telling me that they can't get it under control, but then they tell me that they went out with a friend and had chili and 3 beers, and they're like, I don't know, do you think that was it? And I'm like, no, maybe, yes. So there's still, even though without all the medicines, it won't necessarily be related, when you're really in the peak of it, you just want to kind of go the simple way. What did you do before you had carcinoid syndrome? What did you do when you had diarrhea? You simplified your diet. You went for tea and toast, and you went that direction. Flushing, this is where it is a little unfair, kind of a battle of the sexes comes up, because men will say, yes, I got warm. Someone said I looked red. I didn't sweat. I was fine. And then all my women, and I'm with you on this, 40 to 60, flushing is the hardest thing to describe to your care team, because it's probably one of the symptoms that you had before your diagnosis, and you just said, well, it's menopause. And so that's where, and I was working with our endocrinology group, and one of the endocrinologists was saying, what exactly are you telling your patients is flushing? And I think the simplest way that I've been able to kind of tease it out from menopause, or kind of the hot flashes that some of my female patients will tell me, is that it's a dry flush. So there's no sweating involved in it. But what is really tricky is that you can have a flush and a hot flash all at the same time, and I've been told that happens, and I'm not going to tell you that you're not having hot flashes or flushing. It's just your body is just overstimulated from that perspective, from very different hormones. And so, again, it's just the reason it's happening is one of the things that the body does is, or the neuroendocrine system does, is that when you exercise or work your body, or you're in a warm environment, you're going to want to give off heat. So your small blood vessels are going to get stimulated to dilate so that you can get that heat off. And so that's a little bit of why the kind of redness or that rash kind of comes about. And it's something similar to, I try to tell people, if you exercise, when you come in, are you that type of person that just looks kind of beet red or red after they've been exercising? So it's kind of the thing to look at. I typically, or many of my patients have shared with me that have carcinoid, that it's kind of chest up, and it's kind of this like flamethrower feeling that goes from their chest up to their face. I haven't experienced it, so I'm just taking in what others have shared with me. Sometimes it's red and patchy, so patients who have allergies are just unclear if they're having an allergy or if they're having a flushing event. But again, it's just communicating. What I'm looking for when I talk with my patients is the frequency, the intensity, and everyone's going to have their own way that it manifests. So that's, it's just trying to keep all those in line. But other things can cause flushing, and I think this is where it gets very tricky when someone gets diagnosed and they don't necessarily have carcinoid syndrome, but when I meet them and they start saying, well, ever since I found out I had the diagnosis, I went online, and ever since then, I've had every single carcinoid syndrome symptom that I read about. But before I found out I had it, I didn't have it. I didn't have any of these symptoms. And it's because your body has all of these mechanisms to do these or have these responses for a reason, right? They were normal responses. It's just when you have a neuroendocrine tumor or carcinoid syndrome, that excess stimulus or the hormone is triggering or telling the healthy parts of your body to respond, and your healthy part of your body doesn't know where the signal's coming from. It's just going to respond because it's healthy, right? It's just going to do that. So these are some other things, and I think I've had patients tell me that, they had the flushing or they had the diarrhea, and anxiety was the diagnosis that 5 doctors gave them before they got diagnosed. It's a tricky symptom because so many other things can be the cause. I'm including here carcinoid heart. Again, not something that all patients with carcinoid syndrome have, but it is a very important symptom or side effect of the disease because it can result in such significant symptoms and such significant medical complications. And really all it is that the excess serotonin is putting stress on the heart valves. And so the heart valves are getting thick and then not allowing the blood to pump the way that it should. And so you have, again, the body comes down to a very simple plumbing system. You have leaky valves. And that can put pressure, it's just back pressure, and it can make people feel very short of breath. They can tire very easily. They can have a lot of swelling in their legs. And so it's just important for us to try to identify that as soon as we can, and try to tease out whether or not it's related to carcinoid syndrome by checking things like the 24-hour urine, and then initiating management. And the diagnosis or how we evaluate the heart is with an ultrasound on the heart. So I found this cute little cartoon just to, if anyone hasn't had it, that's the experience you would have. And then the treatment really is reduction of the hormone secretion. So it's the somatostatin analog or the treatment of the cancer itself. And then working at our center, we work with the cardio-oncology team. So you would meet with them. They assess your cardiac disease or how much your heart is working or how much it's impaired and make sure you're on medications to manage that. You'd likely also meet with a surgeon to discuss the options for having a valve replacement, all of those things, all that kind of risk stratification to make sure. If you have early signs or if there's some suggestion that you're at risk, they're working together with the cardiologist. We try to make sure that you're undergoing surveillance and assessments on a regular schedule. Carcinoid crisis is another big question that people ask about because they've had carcinoid and they're going for a procedure and they're calling, they're saying, does my fill in the blank need to know that I have carcinoid and do they need to be ready to do something about it? And carcinoid crisis is different than carcinoid syndrome symptoms in that it just happens out of nowhere, right? And there can be different triggers to it, but really it's just all of the carcinoid type symptoms can happen, the flushing, and diarrhea, the shortness of breath, the swelling, but you can also have shifts in your blood pressure, so either too high or too low. And the triggers, again, spontaneous, surgery, but major surgery like abdominal type surgery is typically reported. Some drugs like epinephrine, people will say, well, I'm having dental work, can they use that? Those are, for that limited amount, not typically an issue, but again, it's important to have this conversation. Anesthesia can be a trigger. Some therapies like embolization, I have here PRRT, but the reports are very low in regards to that. But the prevention piece really is, and I don't know if I've said it too many times, is just communication, just making sure that your care team, if it's not within the care team, your smaller care team, that they're aware that you have the carcinoid syndrome, you're on a somatostatin analog, you discuss with your oncologist or your oncology care team what kind of procedure you're having so that you can kind of determine before you're sitting in the chair or before you're sitting in pre-op and say, what do I do and what do they need to know? And am I at a center or a surgical center that can manage this? So in summary, carcinoid syndrome is just an excess of we call them vasoactive peptides. That's just a fancy term for the neurohormones or the hormones that are made by neuroendocrine cells. They're in the blood, typically associated with metastatic or neuroendocrine tumors that have spread to other parts of the body. Treatment of the neuroendocrine cancer can help control symptoms. There are supportive medications that we use and other interventions that can help improve quality of life, but communication is key. Thank you.